Just 10 years ago, the genetic condition we are unpacking today quite literally did not exist in the medical literature. I mean, it was completely invisible to diagnostic science.
Right, which is just wild to think about.
It really is. And yet today, we have researchers actively using artificial intelligence and, CRISPR to design targeted gene editing treatments for the children living with it.
Yeah, the velocity of that scientific evolution is almost difficult to comprehend. We are looking at a trajectory from total diagnostic obscurity to the absolute cutting edge of individualized molecular therapy, and all of that in just a single decade.
It's incredible. So, welcome to the deep dive.
Yeah.
Today, we are exploring the really complex multi-system reality of PURA syndrome.
And our stack of sources for this one is incredibly comprehensive.
Yeah, we're drawing from dense clinical and genomic guidelines detailing 5q31.3 related neurodevelopmental disorders, plus the latest research pipeline updates from the Florey Institute and JAX Tomorrow.
Right, along with some very specific patient case studies and, of course, vital advocacy resources from the PURA Syndrome Foundation.
Exactly. It's a profound collection of data. And it really forces us to zoom all the way in to observe a single malfunctioning protein at the microscopic level.
And then zoom all the way back out, right?
Yeah, to understand how that tiny microscopic error reshapes a patient's entire lifespan, their family dynamic, and, the global network of researchers racing toward a cure.
It's a massive scope.
It really is.
Yeah.
And if you are a parent or a carer currently navigating this journey with your child, I would say right up front, this deep dive is specifically for you.
Absolutely.
We are going to look beyond the basic clinical definitions you probably already know and really examine the biological mechanisms at play. But we also want to directly address a core theme running through these sources, which is a concept of the oxygen mask.
Yes, the oxygen mask.
Well,
Such a crucial metaphor here.
Right, because the reality that looking after your own mental and physical health as a carer, it's not a luxury. I mean, it is a clinical necessity for your child's ongoing progress. You cannot pour from an empty cup.
You really can't. The demands are just too high.
Exactly. So to understand the day-to-day reality you're managing, we have to start at the foundational blueprint. Let's go back to October 2014 and look at how this genetic error was actually isolated.
So prior to that breakthrough in 2014, clinicians were aware of a broader condition known as 5q31.3 microdeletion syndrome.
Okay, so they knew something was there.
Right. They could see that when a specific, relatively large chunk of chromosome 5 was missing, patients presented with profound developmental delays, low central muscle tone, and severe breathing instability.
But it was a huge chunk of code, basically.
Exactly. The problem was that this deleted chunk contained multiple genes, primarily one called PURA and another called neuregulin 2.
So they didn't know which one was the culprit.
Right. The diagnostic tools at the time simply weren't sharp enough to determine which specific missing gene was actually responsible for the neurological fallout.
I see. It's like trying to debug millions of lines of computer code.
Yeah.
If an entire server rack goes offline, you know you have a catastrophic system failure, but you have no idea which specific line of corrupted code actually caused the crash.
That is a great way to put it. You need an algorithmic search capable of checking every single character.
And that's where the new technology came in.
Precisely.
Yeah.
That is what whole exome sequencing allowed researchers to do. So in late 2014, two independent teams, one led by Dr. David Hunt in the UK and another by Seema Lalani in the US, they published these landmark studies.
Oh, wow. Both at the same time.
Yeah, independently. They deployed that advanced algorithmic search and identified patients who did not have the massive chromosomal deletion.
Wait, so their chromosomes looked intact?
Overall, yes. Instead, these patients had tiny, localized spelling mistakes exclusively within the PURA gene itself.
Just that one spot.
Just that one spot. Yet they exhibited the exact same severe neurodevelopmental phenotype as those missing the entire chromosomal chunk.
So they finally found the corrupted line of code.
They did. And that discovery officially established PURA syndrome as a distinct diagnosis.
Which is huge. But the structural nature of the PURA gene itself, I mean, that's what makes it so incredibly vulnerable to these tiny spelling mistakes, right?
It is entirely unique in that regard.
Let's use an analogy here. Think of the human genome as a vast library of instruction manuals. The vast majority of the genes, the manuals, are broken up into sections called exons and introns.
Right, the coding and non-coding regions.
Exactly. The exons are the actual published chapters of the manual.
Yeah.
The introns are the rough drafts, the editor's notes, the filler material that gets actively spliced out and discarded before the final protein is synthesized.
But the PURA gene is fundamentally different. It is what we call a single exon gene.
So no rough drafts.
None. There are no introns. There is no filler material to absorb a random mutation. It is a single, uninterrupted, highly critical page of genetic code.
Wow.
So if there's a single typo anywhere on that page, like a missense mutation, a frame shift, a nonsense variant, the entire resulting protein is structurally compromised.
And that resulting protein, pure alpha, it's not some minor background player in human biology.
Far from it. Pure alpha is a highly conserved, multifunctional protein. It's essential for cellular homeostasis across nearly all human tissues.
Not just the brain, then.
No, it's ubiquitous. It's in the brain, the heart, the muscle tissue, the blood. It consists of 322 amino acids and features 3 very specific recurring sequences known as PUR repeats.
PUR repeats, okay. What do those do?
They act as molecular grappling hooks, allowing the protein to bind with incredibly high affinity to both DNA and RNA.
Okay, wait. When a protein can grab onto both DNA and RNA, it essentially acts as a master regulator for the cell, doesn't it?
It operates on multiple levels. Inside the nucleus, pure alpha acts as a transcriptional activator. It binds to the DNA and helps regulate whether other crucial genes are turned on or off.
Like flipping biological switches.
Exactly. And it also assists in the physical replication of the DNA itself, but its most critical function, particularly in the context of this syndrome, happens outside the nucleus, in the cytoplasm of neurons.
Ah, and this is where we see the direct link to the developmental delays. Neurons have those long branching arms called dendrites, which form synapses to communicate with other brain cells.
Right. And for a synapse to form, or to strengthen during the process of learning and memory, the neuron needs to build new proteins locally right at the site of that connection.
It can't just wait for the main nucleus to do it.
No, it cannot wait for the nucleus to manufacture the protein and ship it all the way down the dendrite. It takes too long. So pure alpha physically grabs onto messenger RNA, the mRNA blueprints, and acts as a specialized courier.
Oh, wow.
Yeah, it transports those blueprints down the dendrite to the synapse, and it holds them in a repressed, dormant state until the exact moment the neuron fires and needs to synthesize that specific protein.
So if the PRA gene has a typo, the pure alpha courier is malformed. The grappling hooks are broken.
Exactly. It drops the mRNA blueprints before they ever reach the synapse.
That's devastating on a cellular level.
It is. The local protein synthesis fails, synaptic plasticity is severely blunted, and the neural network simply struggles to form the connections required for basic cognitive and motor development.
And it doesn't just stop at the synapses, right?
Yeah.
The sources mention myelin.
Yes. It also heavily impairs the proliferation of neural cells and the formation of myelin. That's the lipid-based insulation that wraps around nerves and allows electrical signals to travel efficiently.
Like the rubber coating on a copper wire.
Precisely. Without adequate myelin, the signals degrade. So the clinical manifestation of this molecular failure is immediate, and it is multisystemic.
And despite how critical this protein is, the sources indicate just how incredibly rare the specific genetic typo is. As of late 2024, there are roughly 706 confirmed cases globally, documented across 60 countries.
Which is a tiny number. The estimated incidence is about 1 in 1,000,000.
Which heavily implies that thousands of individuals are currently living undiagnosed, particularly in regions that lack access to widespread whole exome sequencing.
Oh, without a doubt. Many older patients have likely spent decades carrying generic umbrella diagnoses like cerebral palsy or unspecified profound intellectual disability, never knowing the specific molecular root cause of their condition.
Now, for parents navigating the genetic counseling aspect of this diagnosis, the sources draw a really sharp line regarding how these mutations actually originate. The vast majority of PURA variants are de novo.
Right, meaning they occur spontaneously during the formation of the gametes, the egg or the sperm, or during the very earliest cell divisions of embryonic development.
So they are not passed down from asymptomatic parents.
Correct. Because it is a spontaneous, sporadic event, the recurrence risk for a family is incredibly low. Geneticists quote it at less than 1%.
Wait, if the mutation is genuinely spontaneous, a random typo in the dark, why isn't the recurrence risk simply 0? Where does that 1% come from?
That's a great question. It accounts for a rare biological phenomenon called gonadal mosaicism.
Gonadal mosaicism, what is that exactly?
In this scenario, a parent's blood tests will show completely normal DNA. But a small, isolated cluster of cells within their reproductive organs, their gonads, actually carries the PURA mutation.
Oh, I see.
So while the parent is completely unaffected, multiple eggs or sperm might carry the variant, creating a slight risk of having a second affected child. But statistically speaking, a de novo mutation is a one-off event.
Okay, that makes sense. But the moment that child is born, the theoretical biology of RNA transport and myelin formation, it translates into a terrifying acute reality. The transition from the womb to the delivery room is where PURA syndrome universally announces itself.
Right. Yes, it plunges the family straight into the neonatal intensive care unit. The clinical literature defines this initial presentation through a highly consistent neonatal triad: severe hypotonia, respiratory insufficiency, and profound feeding difficulties.
Okay, let's break that triad down. We hear the term floppy baby thrown around a lot in pediatrics regarding hypotonia, but we really need to look at the specific mechanism here. The muscles themselves aren't structurally broken or dystrophic, are they?
No, they aren't. This is central hypotonia.
Central, meaning from the brain.
The distinction is vital. A healthy brain constantly sends a low-level electrical signal down the spinal cord to the muscles, telling them to maintain a baseline level of tension resting tone.
And that's what allows us to sit up, or an infant, to resist gravity.
Exactly, to keep their limbs flexed. In PURA syndrome, the central nervous system is so compromised by the lack of pure alpha that the brainstem simply fails to generate and transmit that resting tone signal.
So the muscles are fine, but the signal isn't there.
The muscles are perfectly capable of contracting, but the command center is silent.
Now, the clinical guide highlights a specific diagnostic test neurologists use in the NICU. They tap the infant's knees to check the deep tendon reflexes. In PURA infants, those reflexes are usually preserved, which seems counterintuitive if they're so floppy.
It does seem strange, but that simple reflex hammer tap is a major fork in the diagnostic road.
How?
If an infant presents with profound hypotonia and absent reflexes, aphrexlexia, the clinical suspicion immediately shifts toward peripheral lower motor neuron diseases, like spinal muscular atrophy.
Oh, SMA, where the actual motor neurons in the spinal cord are dying.
Right, where the physical circuit is actually broken, but when the knee jerks in a PURA infant, it proves the peripheral reflex loop from the knee to the spine and back to the muscle is fully intact.
So it confirms the deficit is higher up, centralized in the brain.
Precisely, it rules out the peripheral issues.
While the hypotonia prevents the infant from moving, it is the respiratory insufficiency that actively threatens their life in those first crucial days, isn't it? The sources show over 50% of these neonates suffer from recurrent severe apneas.
Yes, and the respiratory failure manifests through two overlapping mechanisms. The first is central apnea.
Back to the brain again.
Right. The medullary respiratory centers deep in the brainstem act as the body's automatic metronome, driving the rhythmic expansion of the lungs. In PURA syndrome, that metronome skips beats. The central drive simply pauses, and the infant stops breathing because the brain literally forgets to send the signal.
Which means parents are sitting next to an incubator watching oxygen saturation monitors plummet, completely helpless as the autonomic nervous system just misfires.
The psychological trauma of that vigilant monitoring cannot be overstated. I mean, going back to your oxygen mask analogy, this is where carer burnout begins on day one.
Absolutely. You're constantly on edge. And you mentioned two mechanisms. What's the second?
Compounding the central apneas are obstructive sleep apneas. The profound hypertonia doesn't just affect the arms and legs, it affects the oropharyngeal muscles, the muscles of the face, tongue, and throat.
So they're too floppy to stay open.
Exactly. When the infant falls asleep, that airway tissue loses what little tone it has and physically collapses, blocking the trachea.
So they require immediate aggressive intervention, mechanical ventilation, continuous positive airway pressure, or prolonged supplemental oxygen.
Yes, it's an intensive level of life support.
But the data does offer a distinct shift in the respiratory prognosis as the child grows, right? It's not always this dire.
Thankfully, no. Unlike neurodegenerative conditions where respiratory function steadily declines, the central drive in PURA syndrome often matures. Many infants see a gradual stabilization of their breathing after the first year of life.
That has to be a massive relief for the parents.
It is, though nocturnal monitoring with pulse oximetry remains a standard precaution for years.
Of course. Now, the third pillar of that NICU triad is dysphagia, or severe feeding difficulty. If the pharyngeal muscles are too weak to hold an airway open against gravity, They are certainly too weak to execute the highly coordinated mechanics of eating.
Safe feeding requires an incredibly complex, rapid-fire neurological sequence. Suck, swallow, breathe. The airway must be protected for the exact fraction of a second that milk passes over the larynx.
And in PURA neonates, the central hypotonia completely disrupts this synchronization.
Over 80% cannot safely take in enough nutrition by mouth. The risk of silent aspiration inhaling fluid directly into the lungs is immense.
Which leads to aspiration pneumonia, right?
Yeah.
So the medical team has to bypass the mouth entirely.
They do. They rely on nasogastric tubes initially, and very frequently transition to surgically placed gastrostomy tubes, or G-tubes, to deliver nutrition and medications directly into the stomach.
And the hypotonia probably affects the stomach too.
It does. It paralyzes the smooth muscle of the lower esophageal sphincter, leading to severe gastroesophageal reflux disease, which only exacerbates the risk of aspiration and respiratory distress.
So looking at this clinical picture, a neonate requiring ventilation, tube feeding, presenting with profound central hypotonia but preserved reflexes, you would think the diagnosis would be obvious. Yet the literature explicitly states that families often endure a grueling diagnostic odyssey lasting years. Why is the clinical presentation alone insufficient to pinpoint PURA?
Because the presentation is severe, but it's not pathognomonic, meaning it isn't unique to a single disease. A clinician looking at that infant must rule out a massive differential diagnosis list.
Like what else looks like this?
Prader-Willi syndrome presents with almost identical neonatal hypotonia and feeding difficulties. Angelman syndrome and Rett syndrome share the severe intellectual disability and later onset epilepsy. Congenital myopathies present with similar muscle weakness.
So without advanced genomic sequencing, doctors are essentially forced to treat the symptoms in a vacuum while waiting for the phenotype to evolve over time.
Right. They're treating the apneas and the reflux without knowing the underlying molecular failure.
It wasn't until the widespread adoption of clinical whole exome sequencing that this odyssey began to shorten.
Thankfully. Today, an infant presenting with the Neonatal Triad can ideally have their DNA sequenced rapidly, identifying the PURA variant within weeks rather than years.
Which allows the medical team and the parents to immediately pivot from searching for an answer to managing the known reality of the condition.
Exactly. It shifts the entire focus of care.
And once that infant survives the intense vulnerability of the NICU, the family enters an entirely new, prolonged phase, childhood development. This brings us to the profound disconnect between the physical body and the cognitive potential of a child with PURA syndrome.
The natural history of the syndrome dictates global developmental delay and moderate to profound intellectual disability. The gap between the child's physical capabilities and those of their neurotypical peers widens aggressively in the first few years of life.
The central hypotonia remains a persistent anchoring force, doesn't it? The attainment of standard motor milestones is severely delayed.
Very delayed. A significant portion of the population never achieves independent ambulation.
And for those who do eventually walk,
The milestone is often reached late in childhood, typically between the ages of 3 and 10. And the biomechanics of their gait are permanently altered. They exhibit a wide-based, unsteady, ataxic gait.
so they're prone to frequent falls.
Very much so, due to the poor cerebellar coordination and core weakness.
Fine motor skills are equally disrupted too. The lack of myelination and weak synaptic connections make the precise motor planning required for grasping, reaching, or manipulating small objects incredibly difficult.
They require intensive, ongoing physical and occupational therapy from infancy, utilizing supportive standards, customized seating, and gait trainers just to maximize whatever functional mobility they possess.
But the most striking developmental characteristic, and the one that really dictates so much of the carer's day-to-day emotional reality, is the profound expressive-receptive language discrepancy.
This is a massive hallmark of the condition.
It really is. It's akin to being trapped in a diving bell. Imagine you have a complete nuanced understanding of a foreign language. When people speak to you, you process the vocabulary, the tone, the jokes. You are fully present in the conversation.
But the neurological pathway connecting your brain to your vocal cords is completely severed.
Right. You are physically incapable of speaking the language back.
The vast majority of individuals with PURA syndrome are non-speaking. They cannot execute the complex oromotor planning required to articulate meaningful words.
However, the clinical reports and the consistent testimony from parents emphasize that their receptive language, their capacity to understand spoken language, follow commands, and process their environment far exceeds their ability to express themselves verbally.
They are not checked out. The cognitive capacity for connection is intensely present. The sources describe their personalities with remarkable consistency. They are highly social, deeply affectionate, observant, and eager to interact.
Which means bridging that communication gap is the single most vital developmental intervention a care team can implement. If a child understands their environment but has no mechanism to interact with it, the resulting frustration can manifest as severe behavioral distress.
It absolutely does. The early and aggressive introduction of augmentative and alternative communication, or AAC, is paramount.
And AAC isn't a one-size-fits-all solution, right? It scales with the child's motor capabilities.
It has to. For some, it begins with low-tech, tactile interventions like keyword sign or customized symbol boards, allowing the child to point to their needs.
And as motor control improves or as technology adapts,
They transition to dedicated electronic communication devices. For those with profound motor limitations who cannot isolate a finger to point, advanced eye gaze technology is life-changing.
how did that work?
It tracks their pupillary movement, allowing them to select words, build sentences, and express complex thoughts simply by looking at a screen.
The advocacy materials include a brilliant anecdote about a 7-year-old girl named Sarah. Her parents were initially cautioned that she might never walk, yet she relentlessly practiced with a supportive walker.
It's a wonderful story.
It is. While her verbal output is limited to a few specific words, her receptive language is incredibly sharp. She utilizes a PODD communication book alongside an electronic device to direct her family, express her infectious giggle, and impose her sheer determination on her environment.
It is definitive proof that the personality, the humor, and the will to communicate are fully intact, waiting for the right tool to bypass the broken neurological pathway.
Facilitating that communication is not just about identifying basic needs like hunger or pain. It is about validating their internal world and allowing them to actively participate in their family dynamic.
Which goes right back to the parent's mental health, too. Being able to truly communicate with your child, to know they're in there, that refills the cup a little bit.
It absolutely does. But maintaining the focus required to learn and utilize an AAC device is monumental when the brain itself is physiologically unstable. And this leads us into the most medically volatile phase of childhood for these patients, the onset of severe neurological storms.
Typically between the ages of 2 and 5, the developing brain hits a critical threshold of instability. And the primary consequence is the emergence of epilepsy.
And it's common, right?
Very. The clinical data shows that over 50% of individuals with PURA syndrome will develop seizures.
And we are not talking about a mild, easily controlled form of epilepsy.
No. Because the PUR-alpha protein deficit is ubiquitous, affecting every single neuron across the entire cerebral cortex, the resulting electrical instability is global.
So it's not just one spot acting up.
Right. This isn't a focal epilepsy caused by a specific localized lesion that a neurosurgeon can simply resect. It is a system-wide failure of synaptic regulation.
The seizures frequently present initially as myoclonic jerks, sudden, involuntary, lightning-fast muscle twitches, and these can occur dozens of times a day, severely disrupting any attempt at physical or cognitive therapy.
Over time, the seizure semiology often evolves into generalized tonic-clonic seizures, involving full-body convulsions and complete loss of consciousness. The epilepsy is notoriously refractory.
Meaning it actively resists standard pharmacological treatments.
Exactly. In many cases, the electrical chaos progresses into Lennox-Gastaut syndrome.
Lennox-Gastaut, that's a devastating diagnosis on its own.
It is a severe epileptic encephalopathy. It is characterized by multiple simultaneous seizure types, a highly specific chaotic brainwave pattern on an EEG, and severe cognitive stagnation.
So it actually halts their development.
Yes. When a child develops Lennox-Gastaut, the sheer frequency of the seizures and the heavy burden of the required medications often cause a regression in the hard-won developmental milestones they have achieved.
The literature details a very specific case study that highlights just how difficult this refractory epilepsy is to manage. But it also reveals a fascinating metabolic intervention. There's an 11-year-old boy with a de novo frame shift variant in his PURA gene. Around age 7, he began suffering from up to 30 flexion spasms every single day.
30 times a day. Think about that. A massive electrical discharge forces his upper limbs to spasm inward, his neck loses all postural tone, and his consciousness resets.
The cumulative concussive toll on a developing brain from that many spasms is just catastrophic.
It is. His neurology team exhausted the standard anti-seizure protocols. High-dose valproate failed to control the spasms and introduced severe, intolerable side effects. Levetiracetam provided no clinical improvement.
So the standard pharmacological toolkit was entirely ineffective.
Entirely. When neurotransmitter modulation fails, neurologists often pivot to altering the brain's fundamental metabolic fuel source. They initiated the classic ketogenic diet.
Now, the general public usually associates the keto diet with, wellness trends and weight loss, but medical keto for refractory epilepsy is a radically different, highly calculated clinical protocol.
Radically different. The goal is to force the entire central nervous system to abandon glucose as its primary energy source, and instead rely on ketone bodies derived from the breakdown of fats.
But how does shifting the metabolic fuel source actually stabilize a genetic electrical storm? Like, what is the connection there?
The exact neuroprotective mechanism of ketones is deeply complex, but the primary driver is the ketone body beta-hydroxybutyrate. When neurons utilize beta-hydroxybutyrate instead of glucose, it fundamentally alters the synthesis of neurotransmitters.
Okay, so it changes the brain chemistry.
It upregulates the production of GABA, the brain's primary inhibitory calming neurotransmitter, while decreasing the excitability of the synaptic membranes.
I see. It essentially raises the threshold required for a stray electrical signal to trigger a full-blown seizure.
Exactly. It makes the brain less reactive. And for this 11-year-old boy, the metabolic shift was a breakthrough. The clinical notes show a drastic reduction in the frequency of his flexion spasms.
But what makes this case study so compelling is that the diet unexpectedly resolved a secondary, entirely different symptom.
Right, the coeluria.
Excessive, uncontrollable drooling. If we look back at the profound oropharyngeal hypotonia and the dysphagia we discussed in the NICU phase, the coeluria makes perfect mechanical sense. The child produces normal amounts of saliva, but lacks the subconscious muscle tone and swallow coordination to clear it.
Yet the ketogenic diet significantly reduced the drooling. It is the first documented instance of this dual benefit in PURA syndrome.
That's fascinating. Why would a diet affect drooling?
It suggests that the metabolic shift doesn't just calm the cerebral cortex. It may also improve the baseline autonomic regulation of the brainstem, which controls salivary gland output and baseline swallowing reflexes.
It perfectly illustrates how intertwined these physiological systems are. And while dietary interventions or vagus nerve stimulation, which essentially acts as a pacemaker to interrupt seizure activity, can provide relief, epilepsy is only one facet of the neurological burden.
The sources outline a broad spectrum of non-epileptic movement disorders that severely impact quality of life. Patients frequently develop dystonia and choreothetosis,
which are involuntary, sustained muscle contractions that force the limbs into abnormal, twisting postures.
And these movements are not seizures. The patient is fully conscious. But the basal ganglia in the brain is sending corrupted motor commands, making comfortable positioning in a wheelchair or bed incredibly difficult.
They also exhibit stereophysized, repetitive, rhythmic movements like intense hand flapping, rocking, or even self-injurious behaviors like hand biting. These often correlate with the child's sensory processing deficits and their inability to express internal anxiety or overstimulation.
And this ties directly into a highly specific diagnostic red flag noted in the clinical literature, the pathological startle response.
I found this part so interesting. A neurotypical startle reflex is highly efficient. A door slams, your sympathetic nervous system spikes, you jump, and within a fraction of a second, your cortex assesses the sound, realizes it's just a door, and dampens the reflex. You calm down instantly.
A pathological startle response is an exaggerated, prolonged, massive neurological overreaction to basic auditory or tactile input.
Why does that happen?
The mechanism behind this exaggerated startle traces directly back to the lack of myelin and poor synaptic regulation caused by the pure alpha deficit. When a sudden sound hits the auditory nerve, the signal enters the brainstem. But the inhibitory interneurons, the neurological brakes that are supposed to contextualize and suppress the signal, fail to fire efficiently.
So the sensory input just floods the system unchecked.
Completely unchecked. The nervous system is hypersensitive and completely incapable of dampening the response. When a geneticist sees a child with global developmental delay, hypotonia, and this intense, uncontrollable hyperacusis, it serves as a massive clinical signpost pointing toward a PURA mutation.
If the central nervous system fails to provide resting muscle tone, the consequences don't stop at movement or breathing. The musculoskeletal system itself relies on dynamic muscular tension to grow correctly. This takes us from the neurology clinic straight to a multitude of other specialists, highlighting the massive multi-system impact of the syndrome.
The skeleton is not a static frame. It is dynamic scaffolding that responds to the forces placed upon it. When the muscles surrounding the spine are profoundly hypotonic, they fail to hold the vertebrae in proper alignment as the child rapidly grows.
The result is severe orthopedic compromise. The clinical data shows that almost half the population, 48%, develops scoliosis, an abnormal lateral curvature of the spine.
Hip dysplasia is also nearly ubiquitous because the hip socket, the acetabulum, requires the constant grinding pressure of walking and bearing weight to form a deep, stable joint. Without that pressure, the joint remains shallow and the hip effortlessly dislocates.
A poignant case study from Poland illustrates the severity of this skeletal toll. A 15-year-old girl with PURA syndrome developed advanced, rapidly progressive idiopathic scoliosis due to her underlying hypotonia.
The curvature of her spine became so aggressive that it began compressing her thoracic cavity, physically restricting her lung capacity and threatening her already fragile respiratory system.
She required massive, complex spinal fusion and stabilization surgery.
And the terror of that surgery is compounded by the fact that the actual density of the bone being operated on is deeply compromised. The literature points to widespread osteopenia and osteoporosis in this patient population.
Why are their bones fundamentally brittle?
Bone metabolism is disrupted by a vicious triad of factors. First, the mechanical void. Bones require the impact stress of weight-bearing exercise to stimulate osteoblasts, the cells that build new bone tissue. The lack of independent ambulation removes that stimulus.
Okay, that makes sense. And the second factor?
Second, they frequently suffer from chronic, severe vitamin D deficiency.
And the third factor is a cruel medical irony. The very medications required to stop the brain from misfiring actively destroy the skeletal scaffolding.
Exactly. Many standard high-dose anti-epileptic drugs heavily interfere with hepatic vitamin D metabolism and calcium absorption. The liver prioritizes metabolizing the seizure medication, neglecting the synthesis of the compounds required to mineralize the bone.
It results in pathological fractures occurring from routine handling or physical therapy. Routine DEXA scans for bone density and aggressive pharmacological vitamin D and calcium supplementation are mandatory protocols.
The multi-system failure extends well beyond the skeleton, too. Let's look at the endocrine system. The sources indicate increasing evidence of anterior pituitary gland dysfunction.
The pituitary gland, sitting at the base of the brain, is the master conductor of the endocrine system. PUR-alpha is highly expressed in this tissue.
When the protein is deficient, the pituitary fails to secrete growth hormone and gonadotropins in a regulated manner. This clinically manifests as erratic, unpredictable growth percentiles and highly abnormal pubertal development.
So some patients experience precocious, early-onset puberty, while others experience severe developmental delay. Managing this requires strict oversight by a pediatric endocrinologist.
Visual impairments are also almost universally reported.
Yes, the hypotonia affects the extraocular muscles that control the alignment of the eyes, leading to severe strabismus or crossed eyes. They also exhibit high rates of refractive errors like myopia and hyperopia.
As well as cortical visual impairment, where the eye functions fine, but the visual cortex in the brain cannot process the image.
Correcting that vision is not just a matter of convenience, it is an absolute necessity. If a child's only avenue for expressive communication is utilizing an advanced eye gaze AAC device, their visual acuity must be optimized.
Absolutely.
Yeah.
And then we have to consider the gastrointestinal system, which is profoundly sluggish.
Chronic, severe, intractable constipation is a daily reality. The intestines rely on peristalsis, the coordinated wave-like contraction of smooth muscle to move waste. The central hypotonia blunts these contractions.
Combine that with a diet heavily reliant on pureed tube feeds and a complete lack of physical mobility, and the GI tract effectively stalls. It demands aggressive daily management with osmotic laxatives and specialized high-fiber enteral formulas just to prevent bowel impactions.
So we have a patient who likely requires G-tube placement, dental interventions due to enamel defects, potential spinal fusions for scoliosis, and corrective eye surgery for strabismus. They're going to spend significant time in the operating room. But the International Orphan Anesthesia Guidelines explicitly warn that putting a PRA patient under general anesthesia is an incredibly volatile, high-risk scenario.
Okay, let's unpack this, because the margin for error during anesthesia is razor thin. The guidelines provide a rigid framework based on the syndrome's unique vulnerabilities. First and foremost, these patients are profoundly hypersensitive to central nervous system depressants.
So the anesthesiologist must fundamentally alter their dosing calculations.
Yes. The guidelines mandate a minimum 50% reduction in standard doses of opioids, benzodiazepines, and certain induction agents. The patient's brainstem already struggles to maintain a consistent respiratory drive.
If you suppress that drive further with standard doses of fentanyl or propofol, the patient will simply fail to extubate. They will not wake up and breathe spontaneously.
The guidelines also definitively ban any ambulatory or day surgeries.
It is absolutely forbidden. Even for a seemingly minor 20-minute procedure like a dental extraction or an MRI under sedation, a PURA patient must be admitted to the hospital for a minimum of 24 hours of continuous inpatient postoperative monitoring.
The risk of delayed, severe central apnea striking hours after the anesthesia has supposedly worn off is far too high to allow them to go home.
The induction and recovery phases are also fraught with the risk of aspiration.
Because of the chronic hypotonia in the throat and the severe gastroesophageal reflux, their airway is highly prone to collapsing the moment they lose consciousness, and stomach contents can easily flood the lungs.
Prophylactic measures, like utilizing a nasopharyngeal airway tube during the recovery phase, are often necessary just to stent the throat open while they slowly regain consciousness.
There's also a specific mandate regarding the temperature of the operating room itself. Active warming is required.
This points back to autonomic dysregulation. The hypothalamus, which acts as the body's internal thermostat, does not regulate core temperature efficiently in these patients. In a cold operating theater, under the paralyzing effects of anesthesia, a PURA patient will rapidly drift into severe hypothermia.
They require forced air warming blankets and warmed intravenous fluids throughout the entire perioperative period.
We have meticulously mapped the molecular genetics, the terror of the apneas in the NICU, the profound hurdles of development and communication, the electrical chaos of the epilepsy, the skeletal deterioration, and the extreme risks of surgery. When you synthesize all of this, what does the long-term prognosis actually look like? What is the reality of adulthood for a child diagnosed with PURA syndrome today?
That is the most pressing question for any family receiving this diagnosis. The very first cohort of children officially diagnosed in that 2014 breakthrough are only just now navigating their teenage years. However, the PURA Syndrome Foundation's global registry has successfully identified and tracked multiple individuals in their 30s, 40s, and 50s who are diagnosed retroactively after decades of living with unexplained symptoms.
And the data from those adults provides the single most important anchoring takeaway regarding the long-term prognosis. PURA syndrome is a neurodevelopmental disorder. It is not a neurodegenerative disease.
That distinction is paramount. They start with a profound developmental deficit, and the gap between them and their peers remains permanent. However, they do not inherently lose the cognitive or motor skills they have fought so hard to acquire, barring a catastrophic secondary event like prolonged, uncontrolled status epilepticus.
Slow, incremental developmental progress can and does continue well into adulthood. Survival into mid-adulthood and beyond is the expected clinical outcome provided they receive aggressive, proactive medical management.
But survival in this context does not equate to independence. The literature is unflinching on this point. Individuals with PURA syndrome require constant 247 lifelong care and supervision for every single activity of daily living. Feeding, toileting, mobility, and seizure management remain permanent requirements.
And this reality brings us directly back to the concept of the oxygen mask. The sheer logistical, physical, and emotional weight of providing round-the-clock, highly specialized medical care for decades falls squarely on the shoulders of the parents and carers.
It's an unimaginable weight.
It is, and if you are listening to this as a parent, this is the most critical intervention we can discuss. The airline safety briefing is the perfect analogy. You must secure your own oxygen mask before assisting others. In the context of PURA syndrome, monitoring your own psychological bandwidth, prioritizing your physical health, and aggressively seeking out respite care is not a selfish luxury. It is a fundamental clinical prerequisite for your child's well-being.
Caregiver burnout is a direct threat to the stability of the patient's medical management. You cannot effectively advocate, administer complex anti-epileptic drug regimens, or facilitate intensive AAC therapy if you are entirely depleted. The clinical guidelines echo this necessity, particularly regarding the transition to adulthood. The transition planning cannot wait until the patient is 17. The guidelines stipulate that the bureaucratic and legal preparations must begin by age 12. Parents must navigate the labyrinth of establishing adult legal guardianship or conservatorship, because the moment that child turns 18, the legal framework surrounding medical consent and financial support changes drastically, regardless of their cognitive capacity.
They also face the terrifying cliff of transitioning from pediatric specialists doctors who've intimately known the child's complex physiology since the NICU to adult medical providers who, in all likelihood, have never even heard the term PURA syndrome.
Families must proactively secure placements in adult day programs or specialized residential care facilities that are equipped to safely manage a nonverbal adult with severe mobility deficits, a G-tube, and refractory epilepsy.
The isolation of that journey is crushing, which is exactly why the advocacy networks highlighted in our sources are so vital. The PURA Syndrome Foundation is not merely a passive support group offering sympathy. They are the logistical and emotional scaffolding for these families.
They recognize the collateral impact on the entire family unit. They have established specific outreach programs like Grand POPS to educate and support grandparents, enabling them to provide effective respite care. They run dedicated sibling support networks, acknowledging that the brothers and sisters of a PURA patient grow up in a uniquely demanding environment, often assuming secondary caregiving roles themselves.
But the Foundation's mandate extends far beyond emotional survival. They are the primary engine driving the global scientific race toward a cure. They are managing a massive global patient registry and funding a global biobank, meticulously collecting the clinical data, the genetic sequences, and the skin fibroblast biopsies from patients worldwide. They are literally building the raw material required for molecular research.
And that research is accelerating at a breathtaking pace. The sources describe the 2024 to 2026 window as an era of unprecedented scientific activity. We are seeing massive international collaborations. At the Florey Institute in Australia, Professor Chris Reed is leading a specialized team utilizing patient-derived stem cells to screen thousands of existing FDA-approved drugs, searching for compounds that can stabilize the specific synaptic electrical misfires caused by the PURA mutation.
The integration between the scientists and the families is remarkably tight. In 2024, Professor Reed and his team walked the Melbourne Marathon alongside over 90 participants, including clinicians and PURA families, actively crowdsourcing the funding required to keep the lab running.
But the most staggering leap forward, the research that bridges the gap between science fiction and clinical reality, comes from a May 2025 announcement. A massive collaboration between the Jackson Laboratory, known as JX, and the nonprofit organization JAX Tomorrow. They successfully utilized CRISPR-Cas9 gene editing technology to engineer a completely new knockout mouse model specifically for PURA syndrome.
The creation of this mouse model is the single most critical bottleneck in rare disease research. You cannot test an experimental viral vector gene therapy on a human child without first proving conclusively that the mechanism is safe and effective in a mammalian model.
By using CRISPR to surgically snip out a highly specific portion of the PURA gene in an embryonic mouse, they engineered an animal that perfectly mirrors the human pathology. These knockout mice exhibit the exact same severe central hypotonia, the identical developmental deficits, and the same fatal seizure activity.
They built a flawless biological mirror. And now, researchers at facilities like the Murdoch Children's Research Institute are using those specific mice to test actual therapies designed to upregulate the remaining functional copy of the gene, or eventually to deliver a synthesized, healthy version of the PURA gene directly into the brain using viral vectors.
And this monumental scientific achievement aligns perfectly with a massive, highly favorable regulatory shift. The FDA has recently formalized a proposed plausible mechanism pathway specifically designed for individualized, ultra-rare disease therapeutics.
For a parent desperate for a timeline, what does the phrase plausible mechanism actually change regarding FDA approval?
Historically, the FDA required massive, multi-phase, double-blind clinical trials involving thousands of human subjects to statistically prove a drug's efficacy. For an ultra-rare disease with fewer than 1,000 known patients globally, running a trial of that scale is a mathematical and logistical impossibility. The disease is simply too rare to secure standard approval. The plausible mechanism route acknowledges this reality.
It dictates that if a research team can definitively prove that their customized gene therapy works perfectly in patient-derived cellular models in a Petri dish and completely rescues the phenotype in that highly specific CRISPR knockout mouse model, if the biological mechanism of fixing the gene is irrefutably sound, the FDA can greenlight the administration of that therapy to human patients vastly faster.
It clears the regulatory hurdles for N-of-1 trials, therapies custom-built for an audience of a single patient or a tiny genetic cohort.
It takes the concept of gene replacement from a theoretical white paper and transforms it into an actionable clinical timeline. We're watching the real-time execution of a targeted scientific roadmap, entirely funded and driven by the parents who refuse to accept the limitations of the diagnosis.
It is the ultimate testament to the sheer force of a mobilized, educated patient community partnering directly with the world's leading molecular geneticists.
As we synthesize everything we've covered today, the essential takeaways of PURA syndrome are clear. It is a profoundly complex, relentlessly multisystemic disorder. It is entirely rooted in a single microscopic typographical error within the PURA gene, resulting in a structurally flawed pure alpha protein that fundamentally disrupts the transport of RNA, the formation of myelin, the regulation of synaptic firing, the maintenance of resting muscle tone, the density of the skeletal system, and the autonomic control of the brainstem.
It demands an intensive, highly coordinated, multidisciplinary medical team to manage the reality of 247 care, from the first terrifying apneas in the neonatal intensive care unit straight through the complex transition into adulthood.
Yet, beneath the severe physical immobility, the lack of verbal expression, the relentless seizures, and the orthopedic surgeries, there is a highly perceptive, deeply social, and incredibly resilient individual who processes and understands far more of their world than their body allows them to articulate.
In an era characterized by shallow information and medical generalizations, taking the time to deeply understand the intricate mechanics of a condition like PURA syndrome is profoundly grounding. It highlights the terrifying fragility of human biology, the reality that the trajectory of an entire life hinges on the correct sequencing of a few hundred amino acids. But equally, it highlights the staggering resilience of the children, the relentless dedication of their carers, and the absolute necessity of collaborative, borderless scientific research.
I want to leave you with one final, deeply provocative thought, directly inspired by the genomic data in our sources. The pure alpha protein does not operate in a vacuum. It interacts constantly with other genetic structures. Researchers have discovered that pure alpha binds directly to expanded, repeating genetic sequences found in entirely different genes, specifically C9orf72 and FMR1.
Those specific genetic repeats are the established molecular signatures for amyotrophic lateral sclerosis ALS or Lou Gehrig's disease frontotemporal dementia and Fragile X syndrome.
Exactly. So consider the magnitude of this implication. By racing to cure this ultra-rare, relatively unknown syndrome in a few hundred children, by pouring immense global resources into understanding exactly how the pure alpha protein transports RNA and stabilizes the electrical firing of synapses, these researchers are mapping the fundamental mechanics of neurobiology. Could they, in their targeted pursuit of a cure for PURA syndrome, accidentally stumble upon the key molecular mechanism required to unlock treatments for major, devastating neurodegenerative diseases that affect millions of people worldwide? Could the foundational cure for ALS be hiding right now within the genetic data of a 7-year-old girl communicating through a PODD book?
It is entirely plausible. Foundational scientific discovery rarely remains isolated. Solving the intricate mechanics of the ultra-rare almost universally provides the blueprint to conquer the common.
It fundamentally changes how we view the value of rare disease research. We began this deep dive talking about debugging a massive system failure, looking for that one corrupted line of code. The diagnostic landscape used to be completely dark.
But the resolution of that algorithmic search is becoming sharper, more focused, and more powerful every single day.
From an invisible unnamed syndrome just 10 years ago to a globally connected biobank funding a CRISPR-engineered targeted cure today. The medical science isn't stalling. We just had to invent a vastly better lens to read the human blueprint. Thank you for joining us on this deep dive. Keep questioning the consensus, keep learning the mechanisms behind the diagnosis, and as always, view the sources and the advocacy networks for yourselves. Take care of yourselves, secure your own oxygen mask first, and we will see you next time.